Next, moving on to the tumors, CNS tumors. So we'll see about very few CNS tumors only. So glioblastoma, starting from glioblastoma, it is the most common malignant tumor, primary malignant tumor. Okay, remember, most common malignant tumor in brain is again metastasis only. But if they are asking specifically for primary malignant tumor in brain, it is going to be the glioblastoma. And glioblastoma is going to be grade 4, WHO grade 4. And here in the new classification, they had changed the mutations. So to call it as a glioblastoma, there should be no IDH mutation. So IDH should be of wild type meaning normal. So IDH should be of the wild type along with chromosome 7 gain or chromosome 10 loss. And third promoter mutations, TP53 mutations or EGFR mutations can be present. So only when you have a IDH wild type with any of these things, we can call it as a glioblastoma. Otherwise, it will become astrocytoma grade 4. And usually these glioblastomas, these are actually glial tumors, right? So they tend to invade the midline, and then it crosses the midline, involves the other side of the brain. So it appears like a butterfly both on gross appearance, on radiological appearance. So here, if you appreciate, it is this part which has crossed the midline and gone into this part. So it is appearing like a butterfly. Same here also. Okay. And since it's a grade 4 tumor, it is going to have a worse prognosis. And microscopically, to call it as a grade 4 astrocytoma, you need two features, either a new necrosis or a microvascular proliferation. So the necrosis we see in a glioblastoma will be called as a serpentine or a pseudo-palisading necrosis. So in this here, if you see, this is the necrotic part. All of this part, pinkish appearance, is the necrotic part, surrounding which you see the tumor cells which appear like they had palisading. Palisading is just nuclear are parallel to each other. So this is called as pseudo-palisading because it is not the true arrangement of the nucleus which are parallel to each other. Because of this necrosis, the tumor cells are made to arrange around this in a palisading pattern. So it is called as pseudo-palisading necrosis. And the necrosis also is appearing as if it is a serpentine, a snake-like pattern or a geographic pattern. So geographic or a serpentine necrosis is seen in glioblastoma. So geographic term necrosis, did we see it somewhere else? Yes, geographic necrosis, we also saw it in Wegener's granulomatosis, which is also called as granulomatosis with polyangiitis, right? There again, geographic necrosis was present. So microvascular proliferation is lots of vessels will be proliferating, and the endothelial lines will be, or endothelial lining of the vessels will be proliferating. And here, if you appreciate, the endothelial lining has proliferated so much that it has obliterated the vessel lumen, and it is literally appearing like a glomerulus. So it is also called as a glomeruloid body. So the microvascular proliferation in glioblastoma, which appears like this glomerulus, is called as a glomeruloid body. Okay. Then moving on to the next tumor, which is medulloblastoma. So medulloblastoma, it is the most common primary malignant tumor of the brain in children. So glioblastoma was in adult, while children, medulloblastoma is the most common malignant. Here again, this is also going to be grade 4, and it usually involves the posterior fossa, especially the cerebellar region. And in children, it tends to be in the midline, while in adults, it tends to be lateral in location. And since it is also known for CSF dissemination through drop metastasis. Okay, so drop metastasis and CSF dissemination can also be a feature of medulloblastoma. And medulloblastoma is an example of a small round blue cell tumor. So it is going to be composed of full of this blastemal components. So undifferentiated primitive cells which are appearing small and dark blue are going to be seen. So in Wilms tumor also we saw the blastemal part, right? So one of the triphasic components will be the blastemal component. So same like that, here also neuroblastoma is going to have that primitive cells. And it is highly radiosensitive also, and based upon the expression of certain proteins, the prognosis of this medulloblastoma will depend. So tyrosine kinase C expression and beta-catenin expression is going to have a good prognosis, while mic amplification, anywhere I told mic amplification is associated with poor prognosis. And here it is going to be, where did we discuss this? L-mic amplification in small cell carcinoma of the lung, right? So anywhere mic amplification is going to be kind of bad. So we have both molecular and histological classification of medulloblastoma. So let us see it side by side. So firstly, we'll have the molecular classification, which is first type will be the WNT type. So WNT type is wherein the beta-catenin or the wingless pathway is going to be mutated. So beta-catenin mutation is present. It is going to be of good prognosis. So usually it is a child, and the child will have the classical morphology, which I told now. So small round blue cell tumor. So classical morphology is going to be seen. Then next pathway, the next classification will be sonic hedgehog activated. So SHH activated, herein the patched gene, PTCH gene or the sonic hedgehog is mutated, and here it will be usually an infant, not a child. So infant or a young adult. So young adult or an infant is being affected, and the classical morphology you see here will be a desmoplastic nodular morphology. So here again, it actually, these cells, with these primitive cells tend to form smaller nodules, and these appear like a nodular in pattern. So desmoplastic nodular pattern is seen in SSH activated. SSH activated is further subdivided into P53 mutated and non-P53 mutated, or T53 normal. So in the wild type, it is going to be of good prognosis. However, whenever TP53 is mutated, it is going to cause some kind of bad prognosis. So this is going to cause bad prognosis. Then group 3 and group 4. The next classification will be group 3 and group 4. So in group 3, neither this WNT or this sonic hedgehog is mutated. So here it is actually the N-mic which is getting amplified along with isochrome 17q. So N-mic is amplified. So this group 3 is having the worst prognosis out of all. And here the morphology can either be that of a classical morphology or an anaplastic or a large cell kind of morphology. So cells are going to look quite anaplastic. So group 4 is also neither WNT activated or SHH activated, but here it is going to have isochrome 17q mutations. And the morphology is again like that of group 3, like classical or a large cell anaplastic morphology. But here, since mic amplification is not there, it is going to have an intermediate prognosis. So group 3 of medulloblastoma has the worst prognosis. Next to that, we'll have SHH activated TP53 mutation. Okay. So this is the microscopic image of medulloblastoma. So in this, you can appreciate it is all appearing dark, quite dark blue, right? So this is the small round blue cell morphology. So a small round blue cell tumor, wherein this is composed of primitive undifferentiated blastemal kind of cells. And here on hyper, if you see, this is a neuroendocrine tumor. So it is going to have stippled chromatin. So stippled chromatin will be present, and along with that nuclear molding, nuclear overlapping, all of these features can be present in any neuroendocrine tumor. And there is going to be a special feature in medulloblastoma called as Homer-Wright rosettes. So Homer-Wright rosettes are nothing but the cells are arranged around the central material. So there is some material and cells are arranged like this around it, like a flower it looks like. So it is called as a rosette. So these Homer-Wright rosettes, the central material is nothing but a neuropil. So this neuropil is present. So we have two types of rosettes usually, a true rosette and a pseudo rosette. So true rosette is one in which you are going to have an empty lumen. So empty lumen will be present in true rosette, While in pseudo rosette, there is something inside the lumen, be it a neuropil or a blood vessel or something is going to be present inside the lumen. So examples of true rosettes will be flex nerve intestinal rosette. So flex nerve intestinal rosette, we all know it was present in retinoblastoma. So retinoblastoma is an example for showing flex nerve intestinal rosettes, and that is an example of true rosette. Also, there are true ependymal rosettes. True ependymal rosettes. These are also example of true rosettes. While pseudo rosettes, neuropil, if it was present, it is going to be a Homer-Wright rosette. While if blood vessels are present, it is also called as a pseudo rosette. That again we can see in ependymoma. So in ependymoma, you are going to have both presence of true rosettes, which has an empty lumen, and pseudo rosettes, which have an blood vessel in the center. Since this neuropil is present in the center here, this is a Homer-Wright rosette present in a medulloblastoma. Okay.